Welcome to the 1984 annual Retro Pro Tournament. We last left Ralphie when he was training hard with his sensei to beat Billy during the tournament. But some people might say there was more chores than actual training. Anyways, the day has finally arrived. Let's go see how he did. And while we're at it, we'll check out some retroperitoneal injuries. When an unstable trauma patient is brought to the OR for an XLAP, the retroperitoneum must be examined for signs of injury, since sometimes these will need to be managed surgically, and sometimes not, depending on what is seen intraoperatively and where the injuries actually are. We're not going to get into those meaty details, since it's a bit beyond the level of this sketch, but we are going to get into injuries to individual organs, so let's get into it. The duodenum and pancreas are closely associated anatomically, are often injured together, and certain management steps can be combined to manage injuries to both, but we'll take them one at a time, starting with the pancreas, with our classic pancreas sponge symbol. Injuries to the pancreas can be devastating. They're less likely to cause hemorrhage than the liver or spleen, but release digestive enzymes that do some serious damage to surrounding tissues. These are also associated with injuries to surrounding organs, like the aorta or IVC. So these types of patients are usually sick. Thankfully, pancreatic injuries are rare and are classically associated with handlebar injuries, like these handlebar-shaped nunchucks, although seatbelts and steering wheels may cause similar injuries. NVCs are the most common cause of blunt pancreatic injury. Their presentation is pretty nonspecific, including nausea, emesis, intolerance to oral intake, and abdominal pain, like Ralphie's bully is currently experiencing. Comeuppance! Finally! Yeah, it's a pretty satisfying conclusion to Ralphie's story. Conclusion! No need to go back to Ralphie's story 30-some-odd years later. If an injury is missed initially or presentation is delayed after the trauma, patients may develop hypotension and progress to septic shock. However, the clinical exam is not very reliable, so imaging is necessary. Whoa, someone looks like they had a bad round. That mascot does not look pleased. Giving him the cold shoulder, and looks like he dumped the water jug over him too. Double whammy! That is not a mascot you want to disappoint. CT can demonstrate direct injuries to the pancreas, including lacerations, hematomas, active extravasation, edema, and fluid collections communicating with the pancreatic duct. Fluid around the pancreas or fat stranding around the pancreas both are suspicious for, but not definitive of, pancreatic injury. CT is only moderately good at identifying injuries for the pancreas. So, ERCP and MRCP can be used to identify pancreatic ductal injuries. So we brought in our usual symbols for those. What a clever camera for looking over the crowd, picture man! ERCP is invasive, but is more sensitive and specific, and allows for interventions like stent placement. MRCP is not invasive, but requires the patient to undergo a time-consuming imaging study, and cannot intervene if an injury is seen. While there is an injury grading scale for the pancreas, it is easier to classify injuries as either involving the pancreatic duct or not. Injuries that don't involve the duct are low grade and are safely managed non-operatively with bowel rest and NPO status to reduce pancreatic secretions, as well as serial exams and serial labs, including amylase and lipase. We've symbolized this with a kid training in the lower grade, no weapons zone, with a shiny, fresh uniform. Peep that brand new yellow bandana. Yellow, like the pancreas, right? NG2 placement or GI decompression and nutritional support with TPN may be necessary for prolonged symptoms. On the other hand, injuries that do involve the duct are considered high grade, and non-operative management is inappropriate. So we're off to the OR, like this kid is, training in the weapon zone with his highly damaged uniform and bandana. Other indications for surgery include instability, as usual, and peripancreatic hematomas, as this likely indicates a high-grade pancreatic injury. What specific surgery is performed depends on where the injury is, with distal injuries, like to the tail, usually getting a distal pancreatectomy, while more proximal injuries are more difficult and may need wide drainage, debridement, or even rarely pancreatic head resection called a Whipple procedure with delayed reconstruction. Complications after traumatic pancreatic injuries are common. The most common is pancreatic fistula. Other complications include pancreatic pseudocysts and abscesses. Pancreatitis and sepsis may also result. Next up is the duodenum. So we've got this very duodenal shaped dragon, just like the shape it makes in the body. Similar to the pancreas, duodenal injuries are rare, but can be very serious due to complex anatomy, especially if combined with pancreatic injuries. They are often from handlebar or steering wheel injuries and will present similarly, with nausea, emesis, PO intolerance, and signs of sepsis if presenting late after the injury occurred. A particular type of injury to mention is a duodenal wall hematoma. It is more common in children than adults, like this kid punching the wall. Where that little piece flew off kinda looks like a hematoma, doesn't it? Hematoma can occlude the lumen, leading to the classic presentation of a proximal small bowel obstruction with nausea, emesis, and intolerance to food, and may have a delayed presentation, up to 24 to 36 hours after trauma. Definitive findings of duodenal injury include obvious duodenal wall disruption, intramural hematoma, or perforation. Findings suggestive but not definitive of injury include wall thickening, free fluid without solid organ injury, loss of wall enhancement, and active hemorrhage. These are the same findings we covered in our peritoneal sketch for general trauma to the GI system, so we added a pretty general abdominal wound to this little stuffed bear. All that stuffing, though, he deserved better. The duodenum has an injury grading system too, but it's easiest to divide them up by whether the injuries involve major structures, like the ampulla of Vater, the common bile duct, or combined injuries with the pancreas, all of which would be high grade, and those that don't involve any of these, or low grade. Stable patients with low-grade injuries without obvious perforation are managed non-operatively, as we did the pancreas, with NPO status, possible NG tube decompression, and nutritional support, and serial exams to identify complications. We've symbolized this with this fresh and not torn green belt on our kiddo in the low-grade training area. Green for bile. See what we're doing? This includes the duodenal wall hematomas that we mentioned earlier, which for the most part will resolve on their own, but surgery may be necessary if it persists longer than 2 weeks, or if it ruptures, causing hemorrhage, either into the peritoneum or into the GI lumen, presenting as an upper GI bleed. High-grade injuries, or patients with evidence of duodenal hemorrhage, perforation, or peritonitis, and hemodynamically unstable patients all will require surgical repair. Just think of this torn belt in the high-grade training area. We covered bowel injury management in the peritoneal injury sketch, and for the most part, duodenal injuries will follow that management. Long story short, primary repair of injuries is preferred, but if necessary, the segment can be resected with delayed reconstruction for severely injured patients. Injuries involving the ampulla of Vater or the pancreatic head are more complex and don't follow this general pattern. They require highly involved and complex procedures, usually in a delayed fashion. A serious complication of duodenal injury is leak from any repairs or anastomoses. Leaks can be prevented with temporary pyloric exclusion. We've added a leaky hose connection to symbolize this. Other complications include intra-abdominal abscesses, which is the most common, post-traumatic pancreatitis, or a duodenal fistula, which is the most fatal. Okay, enough. We're done with all that. Last retroperitoneal organ to cover, the kidney. The kidneys are the most commonly injured GU organ in trauma. Mechanisms of injury include rapid deceleration, like falls in motor vehicle accidents, just like how this kidney shaped punching bag is about to fall, and direct blows to the back or flanks. But in general, we don't recommend using kidneys as punching bags. Mhm. The best indicator of renal trauma is hematuria, or blood in the urine, either gross or microscopic. However, absent hematuria does not rule out an injury. For a CT of the kidneys, delayed images should be taken in addition to standard images to watch the contrast pass through the parenchyma and into the collecting system to check for injuries to these structures as well. This is called a CT pyelogram. Findings on CT that indicate renal injuries include hematomas, lacerations, paranephric hemorrhage, and renal vascular injuries. There is a grading system for kidney injuries, but it doesn't impact management, as all grades should undergo non-operative management in stable patients. Even devascularizations may be managed non-operatively. Surgery is reserved for special cases, which we'll go over in a minute. Kidneys follow similar solid organ injury management as the liver and spleen from our previous sketch, meaning ICU management, serial exams, and serial hemoglobins. Clinical worsening with worsening flank or abdominal pain, fever, or signs of persistent blood loss should prompt imaging. Non-operative management for renal injuries may include IR procedures, like embolization for hemorrhage or urinary drainage procedures. Unstable patients, as usual, should be brought to the operating room. Other indications for operative intervention include persistent bleeding causing hemodynamic instability, injuries to bilateral kidneys like these bilaterally injured gloves, high-grade injuries to a solitary kidney, or persistent or worsening urine extravasation, like this stuff leaking from this bag. In the OR, the goal is to salvage a kidney before removing it, like this repair guy is trying to do. Ugh. These kids. The sign even says no weapons, but do they listen? Such as with laceration repairs or even partial nephrectomy, but total nephrectomy would be the last step. Before removing a kidney, however, you must determine that there is another kidney and that it functions, so be sure to check in with the other side. Imaging from before the OR, including the CT pyelogram or an on-table contrast pyelogram, can help. Well, we're pretty much done with this sketch, but before we head out, I'm a little parched. Let's stop at the refreshment center. Talk about some complications that are relatively uncommon after renal trauma. The most common is urinoma, which is a collection of urine from a leak following an injury somewhere along the collecting system or renal pelvis. Somehow I'm not as parched anymore. Other complications include fever, hematuria, AKI, delayed bleeding, urinary fistula, paranephric abscess, hydronephrosis, pyelonephritis, and post-traumatic renal hypertension. That pretty much finishes up our sketch on blunt retroperitoneal injuries, and sadly, the end of our trilogy of karate-themed sketches. Last thing is the summary. Pancreatic injuries are for the most part rare, but can be devastating. Signs and symptoms of a pancreatic injury include nausea, emesis, PO intolerance, and abdominal pain. Hypotension and sepsis may result if presentation is delayed. CT can demonstrate pancreatic injuries or signs suggestive of injuries like fat stranding or peripancreatic fluid collections. ERCP or MRCP may also be necessary. Injuries that don't involve the pancreatic duct are low grade and may be managed non-operatively with NPO status, serial exams, serial labs, and an NG tube and nutritional support. Injuries involving the pancreatic duct are high grade and require surgery, which can involve drainage, debridement, or resection. Complications following pancreatic injury include pancreatic fistula, pseudocysts, abscesses, pancreatitis, and abdominal sepsis. Duodenal injuries are similar to pancreatic injuries in mechanism and management. CT may demonstrate signs of injury, which are the same as other GI system injury findings. Low-grade injuries may be managed non-operatively with NPO, serial exams, and possible NG tube placement and nutritional support. Injuries involving the ampulla, common bile duct, or pancreas are considered higher grade and require surgery. which generally follows the same management as other GI injuries. A special duodenal injury is a duodenal wall hematoma, which is more common in children and may cause a small bowel obstruction, presenting with nausea, emesis, and PO intolerance. These are treated non operatively, but may rupture and cause hemorrhage, requiring surgery. Complications following duodenal injury include duodenal leaks, abscesses, fistulas, and pancreatitis. The kidneys are the most commonly injured GU organ and are injured in rapid deceleration mechanisms and direct blows. Hematuria is the best indicator of renal trauma. The rest of the presentation is nonspecific. CT scan for renal injury should include delayed images and may demonstrate hematomas, lacerations, paranephric hemorrhage, and vascular injuries. Non-operative management of all grades of renal injuries should be attempted initially, with some exceptions for special circumstances. Non-operative management is done with serial exams, serial hemoglobins, and ICU monitoring, and possible embolization. Indications for operative intervention include persistent hemorrhage, urine extravasation, injuries to bilateral kidneys, or severe injury to a solitary kidney. Every attempt should be made to preserve a kidney, but sometimes a kidney will need to be removed. The most common complication following renal trauma is urinoma. Others include fever, hematuria, AKI, urinary fistula, delayed hemorrhage, hydronephrosis, pyelonephritis, and postrenal injury hypertension. What's next for Ralphie? Unsensing multiple fight scenes for at least 2 more sequels. And his sensei? He'll keep training Ralphie until he goes to Boston and picks up a girl pupil, Hillary. That one isn't going to do so well, but it's okay, because Hillary will eventually start boxing and training with Clint Eastwood. Okay.